After the special address, that's a panel discussion on achieving universal health in dialysis through strategic public and collaboration. Moderator, Ms. Shambhavi Sharan, Manager, Tax and Economic Policy Group, Ernst & Young. Our speakers of the session, Mr. Vikram Vupala, Founder and Chief Executive Officer of Nephro Plus, Mr. Bhaskar Guha, Managing Director and Country Manager, Fresenius Medical Care India Private Limited, Mr. Indranil Roy Chaudhary, the Group Chief Executive Officer, Apex Kidney Care Private Limited, Dr. Saurabh Pokhriyal, nephrologist and co-founder and director, Vitus Care, Mr. Narayan Pense, Vice President, Fortis Healthcare, and Mr. Manish Sadana, President, Poly Medicure Limited. So the structure of the session, we have our session lead, Ms. Vrinda Mathur, who's going to be setting the tone and the context of these discussions here. We'll have a special address by Dr. Ranjan Chaudhary, then moving into the panel discussion, and finally concluding the session, a summary and a conclusion by Mr. Rajneesh Gupta, Associate Partner, India Tax and Economic Policy. With that, I hand over to Ms. Vrinda Mathur, the session lead.
Thank you very much for coming back in time after the coffee. I hope it was strong. May I cordially welcome our esteemed panel. The first title, of course, is Achieving Universal Health and Dialysis Through Strategic Public-Private Partnership. As well as the public sector, with the support of EY in terms of conducting a lot of research and releasing the white paper earlier today. I would like to, in particular, thank Dr. Ranjan Chaudhary in terms of the efforts that he has taken in providing guidance periodically through this. Sir, if you'd like to come here or probably for a special address and share some of your thoughts before we discuss the panel discussion.
Okay, good morning to all of you. And I bring greetings from National Health System Resource Center on behalf of my Executive Director, Major General Atul Kotwal. I would like to thank NATHEALTH to provide this platform, particularly Mr. Siddharth Bhattacharya. And I must also, at the same time, thank Ministry of Health and Family Welfare and all my service partners whom I am meeting here. We together have been having a lot of sessions. We have multiple sessions on dialysis particularly. I remember last year we had a workshop on One Nation, One Dialysis concept. And there also I interacted with all our service partners. So it's very beautiful moment to see all of you here together. And I'm sure with such type of effort, bringing the private sector as well as the government sector together, we can build up a very robust ecosystem in the country. And talking about the dialysis, you all must be aware that this is one of the most leading flagship program in the country. Before 2016, the dialysis sector was really unorganized. And there were a lot of unmet needs. Any paper you pick up, you will see there is no clarity about what is the demand, how much are the patients. So in order to mitigate these issues, at least for a start, the government of India, rolled out this Pradhan Mantri National Dialysis Program. Now, what it aims to is to set up dialysis centers at every district in the country. As you are aware, there are 750 odd, districts, and it is heartening to know that by now we have covered 654 districts. So a gap of 96 still stays. There are multifactorial, issues regarding this gap. Maybe the accessibility, and for universal health coverage, that there are three pillars: the accessibility, affordability, and the quality. So at least the first step for accessibility we are looking at to saturate all the districts in the country. First, when we saturate all the districts, then we come down lower. The second target would be a dialysis patient should get the dialysis services uh, within 60 kilometers from his residence, so that his daily life is not disrupted. So that's the major agenda. uh, we have been given a task by 31st December to saturate all the districts in the country. There are certain issues like in far-flung northeast areas where accessibility is very, very difficult. So I had a workshop in Guwahati also with all the service partner, and there are a plethora of challenges, like the geography doesn't allow them for having such scaling up operations. Uh, they have resources lacking as far as trained manpower, as far as equipment, maintenance. A lot of issues are there. But I'm happy that during this state midterm reviews, we heard Manipur also scaling up. We have found Nagaland scaling up. We have found Meghalaya scaling up. So my request to you all is to chip in. This is the time when the Northeast should be a place where you all can make a lot of difference. If you all can go there and establish, support them in setting up, the centers, we will be doing a very good job, and we'll be very, very satisfied lot. Uh, this is very important in the dialysis, that we provide quality. So I talked about the accessibility. Accessibility is not only in the district level, but we should come down to the community health centers and to the where you have a physician at least, so that a dialysis unit can be run. So in the IPHS, we have factored in 50 bed and above. All health facilities also have a dialysis unit. So that's the importance what we are giving for the dialysis in the country. So in case you don't have space in the district hospital, then it's advisable you set up dialysis units in the SDH, like in Tripura we have allowed. Uh, and another one or two states in Telangana and other places, you can go down to the CSC's level, up to CSC level. There's an issue of many a times we were discussing about a standalone dialysis unit. Of course, that's always better. But you, as you all are aware, the emergencies are associated with dialysis, and for that, there has to be a mechanism wherein you go to a either a revenue sharing model, so that you have a tertiary care hospital nearby. And this issue has been handed over to DGHS, who has formed a team, technical team, to study this issue on standalone dialysis centers. I'm sure they will be deliberating and soon coming out with some guidelines. So this is one of the factor which the dialysis ecosystem will benefit in case we have many dialysis units and stations. But we recommend usually within 3 kilometers of our district hospital, as the necessary medical help is available. Of course, dialysis units in tier 2 and tier 3, we can promote them as co-located to our, as I said, nearby some tertiary care hospital. So for that, let's wait for the DGHS to submit a report. They are dwelling on that, and I'm sure it will be out soon. Third comes the quality of service, quality of care. And the quality of care and service, we had a lot of discussion in that. And I'm really thankful to my, service partners. They had found out certain issues in the earlier erstwhile guidelines, and regarding the water standards, the army standards, we have rectified, we have taken cognizance into it, and a big thank you to you all. And the revised bid document has been issued to all the states, which incorporates the best of the water standards. uh, and for that, I think the states will also benefit. We have included a model tender document also, so that the states can quickly resort to that model document and can bid for a RO plant. And when the center readiness is there, there are partners who are willing to provide machines, willing to set up the centers and all. Another aspect is the training, which is a very, very big challenge and a big issue. Uh, we have some models like in the country, the NHM particularly, where we engage in a contractual basis. Uh, though I am aware the the honorarium what we give is very, very pittance. So a dialysis technician would join, if we think of certain better HR remunerations. Obviously, that is one of the agenda for the HRH to look into it. But there are programs like the National Skill Development Corporation. They run a 1-year program for dialysis techniques, which is 7,500 they cost, and a dialysis technician, which is 30,000 per annum. 1-year courses. So I'm sure there are other courses also, but we have to promote this training, because the more trained skill power you will have, the more ease of operation and quality we will get in. So the training is a big gap which I foresee in this whole thing. And the third is the supply chain of the consumables. See, the peritoneal dialysis complements the hemodialysis, but unfortunately, the peritoneal dialysis has not taken that much of, it has not been scaled up by the states. I don't know, it's a fear or some sort of lack of understanding. We are trying to promote the peritoneal dialysis in every state, particularly in the hilly states, northeast, where it's remote location. It will be wonderful, but then they are looking for a assured supply chain mechanism. Now that assurance only you all can give. It's government can never give a assured supply chain. So it's my earnest request that we must try to promote the peritoneal dialysis where the hemodialysis is not possible, or equally in the areas where accessibility is a big concern. So we must do that. And it reminds me, many people say that hemodialysis, the person lands up with infection and all, how long he will survive. So I was going through one of the paper. There's one, I think, Chikmagalur gentleman, 51 years old, and he had been the longest survivor. That's what the net said, 25 years on hemodialysis. And he was thanking. He's become a motivator and an influencer. So we must also do a study of the, longevity, some aspect, so that we can at least give some good stories, success stories of the hemodialysis, and how nicely we are doing as a PPP mode. Because the mere fact, I can say, we don't receive any complaints, major complaints from any of the part of the country. It shows that the program is done in right interest and in right favor. Now, last year we also thought of introducing a digital platform, and I'm very happy to say, under the guidance of my JS policy, we launched the PNDP portal, and it's now used by every state. Very soon we are going to link the payment also with this portal. Now the portal uses the Aadhaar ID, so the people with the Aadhaar ID, they are having the line listing. I had talks with the NHA, and we are getting the data from the NHA also. As so there will be one PNDP beneficiary or a PMJ, and then we are finding the data, so that we are trying to build up a state level renal registry, and then if you connect, you'll have a national registry. So till now, I can say the IT platform has been accepted well by all the states. They're using it. One or two states, few have certain issues, which we are looking into it. We have developed APIs also. We have been requesting all of the states to come out and use this. Even the medical colleges, the private hospitals, they have been also requested to please use this portal. PNDP portal is extremely user-friendly portal, simple portal, and that way you will do a national service. You will capture all the data, and then you can make out where is the demand. So the waiting list, if you say till now, like last this year beginning, we started the waiting list module. Around 110 of the waiting list have been generated, because they have been reported there and recorded there for the facility. Is the end user is the facility, so we have given all controls to the facility, so that we get a real time view of the load there. So now, as you all also know, that there is a urgent requirement of case finding and detection in the health and wellness centers. In the Ayushman Bharat HWC, we have this package of population screening and all. But this particular dialysis, chronic kidney CKD, has a very severe challenge. It actually, how you find out is little difficult in the community, because you have to follow it over a 3 months period of a high serum creatinine, low GFR, and then albuminuria, and then again, as the clinicians will tell better. So ultimately, his GFR comes below the 15, he reaches to the tertiary end, and then he is given the dialysis. So I think there is a lot of opportunity here, how to standardize and find these guys at the earliest so that prevention can be done. So this is a big factor. What we are working, we are trying to find out the POC devices. Many startups have come out with microalbuminuria and the CKD functions in the urine within 2 hours. Those point of care devices we are inviting in the innovation portal so that we can do an HTA, we can validate with ICMR, we can support them. And the National Innovation Health Portal, is looking forward to such type of good scalable innovations, which will make a significant impact in our healthcare delivery system. So that's all I can sum it up in short. I'm sure there are many, many gaps and many facets. And I would like to stop here. Thank you for a very good patient hearing. Thank you.
Good morning, everyone, and a very warm welcome to our esteemed panelists for this discussion on achieving universal health in dialysis through strategic PPPs. So this panel discussion will be divided into two segments. The first segment we'll be discussing the problem in detail through the lens of various stakeholders here pertaining to dialysis. And in the second segment, we'll discuss what are the solutions. How do we take dialysis forward and achieve universal care? So just housekeeping rules that we have a very good panel here and we'd like to hear everybody's point of view. So we hope every speaker could keep their remarks to 5 minutes or so that everybody's point of view is heard and discussed in detail. So we'd like to start with Vikram sir, actually. Dr. Chaudhary already discussed on the issue of actually identifying these ESRD patients. So, sir, according to you, how does India stand in terms of estimating the demand for dialysis in India, and how can the private sector, along with the government counterparts, actually estimate the dialysis requirement in the country?
Sure. Thanks, Shambhavi. Good morning, everyone. I think firstly, estimating the demand, there is a key statistic we all need to be aware of. 85% of the patients who need dialysis today in India die every year. Only 15% have access. So the demand side versus the supply gap is tremendous. And we all talk about growing India, more powerful India, but we cannot let ESRD patients, 85% of them die every year. 13 years back when we started, it was 95% of the people were dying because of the PMNDP program, Ayushman Bharat, few state PPPs, that 95 has become 85. But we can't do 10% every year for the next 5-6 years to save lives, right? So I think from a demand side, as I travel across the country, there is significant lack of supply, and it's primarily driven by affordability and access. Majority of the dialysis centers today are present in big cities, and if you talk about quality capacity, it's highly skewed towards the top 20 cities, quality capacity. I think we need to make sure that the supply increases drastically, and this is where how do you increase the supply? Where do you invest in that capacity becomes a big challenging problem for the government. We highly recommend, the entire dialysis service provider community highly recommends that there should be a renal registry study done every 5 years. It need not be done every 1-2 years, but where the ESRD population is mapped on a district by district. Where are these clusters of patients present in each district? The government should invest in this study, and private sector is happy to collaborate with the government on that. But now what happens is a state government comes up with a PPP, they go to the deepest part. Every taluka needs to have a 2-bedded dialysis center, right? 2-bedded dialysis center, 3-bedded dialysis centers Dialysis is a high fixed cost business. You need minimum 8 to 10 beds capacity in order for it to sustain. As a country, we cannot pay 10,000 rupees per dialysis. India is 138 in the global per capita index. So we need to figure out the efficient way for which we believe 8 to 10 beds is a balancing act between the affordability and the sustainability. Now, that renal registry, once it's created, then it will say which clusters are there for the patient population. You would be shocked to know that 60% of the patients, per a recent study, travel more than 50 kilometers to access dialysis. Imagine traveling 3 times per week to access dialysis. So many patients give up in the first year. After 1 month, after 2 months, the family gets tired. The attendant has to accompany the patient because they're weak. They're getting only twice per week instead of thrice per week. It's a Herculean problem. Now, once the renal registry is done, once the clusters are identified, then we can create a hub and spoke model. The hubs will be larger units where the density is higher. The spokes will be smaller units, which are 8 to 10 beds. Right? Once the renal registry mapping is done, we recommend that the government strengthen the capacity using very well-designed PPPs. The private sector is more cost efficient. The private sector is much faster in deploying additional capacity. The private sector is capable of raising funding from private equity, venture capital to deploy and create this massive impact, right? But the PPP, well-designed PPPs are an answer for to address this demand supply gap that currently exists. Another thing, I'm sitting between two women here. I have to make a point. Since last 13 years, since we started, only 30% of our patients are on, only 30% of our patients are female, 70% are male. If you ask any nephrologist, if you ask any clinician, there is no bias. If the disease affects men and women equally, only 30% of a patient population is female. From an access perspective, we also need to think about how to increase the gender equality from an access perspective. But to summarize, I think there is tremendous gap in terms of demand and supply, but the supply has to be well structured through a renal registry study, and the small taluka level dialysis centers won't work. Private sector won't participate in them.
Thank you, sir, for pointing out how much more effort is needed to reach the last mile for dialysis. I'd like to ask Mr. Guha now on what are your views on the dialysis delivering capacity in India? Are we prepared to meet the demand?
Shambhavi, thank you for the question. Good morning, everyone. I'll try and probably add some data to what Vikram just said. We estimate about 200,000 patients that we have currently who are actively on dialysis. The government estimates about addition of 220,000 patients on ESRD, which means about 34 million to 35 million dialysis would be required on a yearly basis for these patients which are getting added. Approximately, there are about 44,000 machines that exist in these clinics. About 3,300 nephrologists. So when I look at it from a capacity standpoint, I think we are a little inadequate. And when I point out inadequacies, it can be multifactorial, not only from a capacity that exists from an infrastructure standpoint, but also the capability of the technicians and nurses who exist on the ground. That's one area that I see an inadequacy. The sheer reimbursement that we have for dialysis, it does not make it a great point for centers to run at a great operating level. Also, the gap of quality, which I think Vikram mentioned between a good dialysis center to an average dialysis center, is glaring. I think a few of the recommendations that we have made in this paper is taking all of this into consideration, which is around capability building, which is around reimbursement, and how do we build capacity for the future.
Thank you, sir. We now even want to understand what are the key challenges faced by the private sector here in delivering dialysis capacity. For this, I'd like to request Mr. Chaudhary to provide his views.
Thank you, Shambhavi. Thank you, NATHEALTH. I think the major challenges that a service provider sees today is the lack of skilled manpower in this country. This is a very important challenge, whether it is the dialysis technician, the dialysis nurses, even the doctors, the dialysis physicians. We know there's a huge gap in supply and demand in terms of the nephrologists. But to run a dialysis center, we do not require a nephrologist every day. There can be a periodic visit once in 14 days or once in a week. But dialysis technicians and dialysis nurses are a scarcity, and lack of their knowledge is a big challenge. Now we are working very actively with the government along with NatHealth, and some of the recommendations are already listed in the white paper released. So hopefully we are going to scale it up very soon. There are various recommendations both in terms of short term and long term. The other challenge that I foresee is the high cost of delivery, and this is something related to the supply chain, which Dr. Roy Chaudhary already pointed out in his speech in the morning. So just to give you some figures, if you look at the customs duty, there is about 7.5 to 10% customs duty which the government has imposed on import of key dialysis materials. Most of the things are not made in our country, whether it is a dialysis machine or the dialyzer. There are some efforts going on, and hopefully that will soon see the light of the day, but at the moment they are not available. Also, what increases, another fact I would like to highlight, between 2015 and 2021, if you compared the import of dialysis materials in US dollar, this has almost tripled. So this shows the huge challenge on the supply chain, and that puts a challenge on the high cost of delivery. Now, coupled with that is the low price points that we have in our country. So just to give you an idea on this, even a country with similar economy, whether it is Thailand or Mexico, there the reimbursement for the patients is to the tune, per session I'm talking about, is to the tune of $150 to $200. Whereas in our country, this is as low as 25 US dollars. If you look at the government allocation in a country like Bangladesh, which is much smaller, whether in size or population or economy, the government allocates about 4,000 US dollar per year for the treatment of the dialysis patient. Whereas in our country, this is somewhere around 2,400 US dollar. Significant gap. So high cost of delivery and very low price point puts a tremendous strain on the margin of the business, and hence sustainability remains a concern for the service providers. The other point which I would like to highlight here is the lack of patient awareness. Now, this point, in my view, is very, very critical. I think the government, we all know, has done a tremendous job in terms of making the population aware of the tuberculosis and its effects. Now, if a patient is made aware jointly by the government as well as by the service providers on the necessity of 3 times dialysis in a week, that will be of immense help. I myself have visited multiple rural centers, because India is a vast country. There are large states, huge rural areas where still the patients are very primitive in their thinking about coming to the dialysis center thrice a week. I agree with Vikram on the challenges he pointed out, but also the challenge remains that the patients do not believe that they need to come to the center thrice to get dialyzed. So this is a very important challenge that we face, and we need to address that. Along with that, there are a few other points like lack of well-defined quality parameters, as well as there's no proper measurement of the outcome. Let's all understand, whether it is a PPP program or whether it is a different state schemes, at the end of the day, this is a public money which is being utilized by the government. So there has to be justified outcome, and there has to be a justification what the government is gaining by spending this money. To do that, it is important and imperative to measure the clinical outcome. So, of course, with NatHealth, we are working with NABH to define those, and we are very hopeful those are going to very soon be, implemented. But these remain the challenges. Now, on the government sector, in addition to all these challenges, I am forced to highlight the challenge remains is the erratic payment timelines. Now, as I already mentioned, very, very low EBITDA margin. Many places, the EBITDAs are wafer thin, single digit. And then when you have a payment delay of 6 to 8 months, practically nothing remains. So the sustainability becomes a very big challenge. And even in the private sector, the government does talk about that we are now setting up enough private centers to get them empaneled in the different schemes, but empanelment still remains a challenge. Again, that is one area we are working very actively. I'm very hopeful, we are very hopeful as an industry that we will soon see a significant change, and this should bring about a sea change in the way the service is being delivered in this country. Thank you.
Thank you, Indranil sir, for such a comprehensive discussion on the challenges and especially highlighting how important it is that patient visit the center 3 times in a week. On this topic, I'd like to request Dr. Pokhriyal to provide his views on, from the patient's perspective, what issues prohibit them from undertaking the prescribed practice of three.
Thank you,
Session.
Shambhavi, and good morning, everyone. So I think part of this question has already been covered by both Vikram and Indranil and also Dr. Chaudhary in the beginning. The number one reason remains affordability in our country. If we take even the base rate of say about 1,500 rupees per dialysis session, like Ayushman, and a patient requires 12 sessions of dialysis a month, that's 18,000 rupees a month. That's just the cost of dialysis. It does not include the cost of medications. It does not include the cost of the lab tests the patients have to undergo every month. So if you add that to the 18,000, you end up with a number around 25,000. Now, how many patients in India who are not covered by insurance or some undergovernment scheme can afford that? So number one remains affordability. PGI Chandigarh and in Kerala, there have been studies done in looking at patients who've been covered by government schemes, as well as patients who pay out of their pocket. And they've looked at what are the out-of-pocket expenditures which patients incur apart from being, paid government money. In Chandigarh or in Punjab state, the cost of dialysis, which is subsidized by the government, works out to nearly 3,000 rupees per dialysis session. And the out-of-pocket expenditure for every patient, when they have to have a relative accompany them to dialysis, the lost wages of the relative, the lost wages of the patient, payment for transport, payment for food, adds up almost to the same number of nearly 3,000 rupees. So you're looking at patients, even on free dialysis, paying nearly 2,000 to 3,000 rupees out of their own pockets. And so affordability remains number one. There have to be ways to kind of support patients, the vulnerable patients, in this regard. And the second, which Vikram spoke about, is most of our patients, especially in rural areas, have to travel long distances. So accessibility, if we don't have accessibility, none of these patients are going to be able to sustain this for a long period of time. You can have a patient start dialysis, come 3 times a week, travel, 120 kilometers back and forth, but 3 months down the line, they're going to burn out. Their relatives are going to burn out. They're going to burn out from a financial perspective. And so they're going to stop dialysis. And that's why you see this huge number, 220,000 patients a year require dialysis. But in the long run, we see only 220,000 get some form of renal replacement therapy. It's not just dialysis, it's hemodialysis, peritoneal dialysis, or a transplant. 200,000, as we nephrologists like to say, are lost to follow-up. What is lost to follow-up? Lost to follow-up essentially means that these patients did not survive. And that's, you adding up that number every year. So I was very happy to hear what Dr. Chaudhary said, that by the end of this year, hopefully we should be able to cover every district. But for that, I would also like to add what Vikram said, that covering every district means we shouldn't have just 2 dialysis machines per district. We need to have larger numbers. We need to have support for dialysis patients, both from a financial perspective, look at out-of-pocket expenditures of the family, and also make dialysis affordable and accessible for all the patients.
Thank you, sir, for providing us your insights on the issues that restrict the patients from actually getting the sessions. I would now like to request Dr. Pense to talk about the dialysis standards, because ensuring these standards would be essential in reducing the mortality associated with dialysis. Dr. Pense.
Thank you, Shambhavi, and thank you, NATHEALTH. While we do address the acute problem, which is the wide gap of access to dialysis centers across the length and breadth of the country, I think it's equally important to look at standards of care and quality standards and safety standards. Uh, there are various stakeholders, including nephrologists, including dialysis technicians, dialysis providers, and that is being addressed by various forums. But what is need of the hour probably is also to have one single reference source which defines all these standards, standards related to facility and infrastructure, standards related to drugs and consumables, standards related to credentialing, qualification criteria for human resources, for water testing, for diagnostics, and most importantly, to link them up with the quality of care being provided and clinical outcomes that we have been talking about. This report that has been put together by NatHealth with contribution from all the stakeholders and with the knowledge partner is an excellent starting point. NABH has also, agreed to help out in addressing this part. The dialysis standards are also being included in the soon to be released standards for allopathic clinics by NABH, which is again a fantastic, first step for something like this. Of course, the basic minimum standard should be defined as soon as possible and rolled out, and they can be further built on. Like NABH today has various sets of standards for entry level and subsequently for full accreditation, etc. Some kind of that system can be worked out and ultimately linked to the reimbursements also, which is also one of the pain points which has been brought out. So yes, need of the hour to define these standards. Already a few publications, few standards exist, like standard treatment guidelines, like the Pradhan Mantri National Dialysis Program, etc. But all to be neatly put together in one single reference source, defining the standards of care for hospital-based or standalone dialysis, centers is something which is acutely needed. Thankfully, work in progress, and very soon we should have something comprehensive which addresses this.
Thank you, Dr. Pense, for your insight. Now, another part of the whole dialysis delivery is the medtech. For this, I'd like to request Mr. Sardana to please elaborate on what are the challenges faced by the medtech providers to support the service providers so that we can have good quality dialysis.
Thank you very much. Thanks, Natal, for having me here, and good noon, everyone. If you can see for the start, medtech is already on the right side of service providers, so which is a good start. Now, see, a standardized, predefined quality is non-negotiable, especially when it comes to this field, because we are in healthcare, so it's life-threatening. It's linked to life, sorry. Now, for a service provider to continue providing quality, commercial sustainability is of utmost importance, because if you cannot sustain commercially, you will not be able to provide quality continuously, at least to remain float, not to bleed. Now, medtech takes away a good chunk of the capex and opex a service provider puts in. Right? There's where the medtech is. My biggest challenge, or maybe a medtech's biggest challenge on a day-to-day basis, is how do I balance my commercial sustainability with the service provider's commercial sustainability? Unless and until both are balanced, right, the things will not work. Now, that's what we keep on doing. Now, increase raw material cost, increase freight, what else? Increase strengthening forex, rather depreciating rupee. These are all which put pressure on my cost. But my realization is not going up. My realization is either stuck or is going down. Similarly, for a service provider, I don't think even their realization is going up. Right? So that's where we are in a catch-20 situation. How do we support each other? So I think if I can propose a solution or as an opportunity I see, so scale is the only opportunity there for us and for the service provider. And that's where I see ONOD, the One Nation, One Dialysis. It's not only going to treat the patients, it also brings in scale for a service provider and also ultimately brings scale for me. And that's where I see that I'm looking forward. And if we can all together make ONOD success, I think it's win-win for all of us. Thank you very much.
Thank you, Mr. Sardana. Now, we have discussed all the issues in great detail. So we should discuss what are the solutions. How do we achieve universal health in dialysis? And for that, I'd like to first ask Vikram sir, to achieve universal health in dialysis, how should PPP be reformed or structured to ensure accessibility and quality?
Thank you, Shambhavi. I think the PPP is the answer for India. We all agree because dialysis is a chronic spend from a patient perspective. Unlike a kidney stone surgery or a CABG, people have to come to the dialysis center 3 times a week, right? So, but PPPs have been going on for the last 10 years in India. We have lately started participating in few select PPPs, but many of them have significant design challenges. And hence we are very, very picky about which PPPs we participate. We find well-designed PPPs so rare that we have gone beyond India. We have partnered with the Uzbekistan PPP to redefine dialysis there. We went to Philippines in PPP model to serve patients there because in India the PPPs are not very well designed. When I talk about well-designed PPPs, I mean from a capex investment perspective, the machines, dialysis machines, account for the majority of the spend, the medical infrastructure, the machines, the RO plant, the beds, and so on. And these, in general, in India, remaining life of those equipment, right? So a well-designed PPP will ensure a 10-year tenure. It can be 8+2. If there are no problems, the next 2 years are extended. That's the number one design issue that we have. Secondly, we already talked about it 15 minutes ago on the size of the bed, size of the unit. Now, ideally, we should be the closest to the patients, which is home hemodialysis or home dialysis. That is way, way too expensive for a country like India. And hence, the balancing act between how far the patient has to travel versus how affordable it gets from a taxpayer spend perspective becomes important. And hence, we highly recommend a large hub, like a big district headquarters, 25 machines. You would be shocked to know that we run about 50 out of 315, about 50 are in the PPP space. All the PPP centers are full. The patients cannot get slots. All the centers. Many of the centers are running fourth cycle, which means patient comes at 10 p.m. in the night and leaves at 2 a.m., 2:30 a.m. in the morning. It's criminal to ask patients in remote parts of the country to come so late. So the hubs can have big centers, the spokes can have 8 to 10 machines. That's the design feature. Now, it's very idealistic to say, hey, I want to have it in very small talukas and 2-bedded centers, 3-bedded centers. They don't work. We have been doing this for 13 years. They don't work. Dialysis is a high fixed cost business. The clinical audit, the operational audit, the financial audit, many of the PPPs ask for doctors to be stationed, MBBS doctors to be stationed there. It's a high fixed cost. So the structure has to be identifying the cluster, the density of the cluster, and depending on the density, figure out where that 8 to 10 bedded units can be placed so that you're optimizing on the total distance traveled by the patients in that cluster. Right? That's the design second feature. The third thing is from a reimbursement perspective, Indranil already mentioned about this. We run 3 PPPs in India right now, and on an average, we get payment in about months to 8 months, um, with the reimbursement level at 115, the price in US, $300 versus $20 for some of the PPPs, 25 if we are lucky. The working capital burden is immense, right? So the reimbursements have to be timely for private sector to proactively participate in PPPs. The final design element, there is a fundamental flaw in our PPP system or project system, which is no accountability on the safety aspect for dialysis service providers. Now, quality, when we talk about quality, we think about the bells and whistles. Hey, for access, first we need to improve the access. But dialysis can be very risky for the patient life. Mortality can happen. Cross infections can happen. Where is the accountability? So we, the government, the regulatory stakeholders have to bring accountability for service providers on clinical safety. The white paper that has been launched today has mentioned 4 clinical outcomes that need to be published by every dialysis service provider to make sure they're not playing with people's lives. It's very easy to get aggressive and go and participate in projects with an unsustainable price point, putting patients' lives at risk. But it's important for the accountability from a safety aspect. The government needs to ensure the 4 primary indicators are factored into PPPs and make service providers accountable for delivering safety. Whenever we talk about high quality, we think it's like bells and whistles for a country like India. No, safety is paramount for a country like India. Basic quality is mandatory for a country like India to make sure patients' lives are not lost. These are the 4 design elements. Shambhavi.
Thank you, sir, for providing us such rich details on how PPPs can be transformed. And now I'd like to request Mr. Guha for providing us what are your views on the defining features of One Nation, One Dialysis after learning lessons from the PMNDP program.
Oh, I think first and foremost, big compliments, to the government for the PMDP program. I think program, and we truly believe where we want to go from here to One Nation, One Dialysis, possibly. I think it becomes probably like a watershed moment for all of us, who are in this industry. The learnings that we have, I think the first thing I would want to say is around the affordability piece. While we know that, the reimbursements are not adequate, and in a country like India, we need to be affordable. But if you look at the capacity, I think Vikram and Ranil spoke about it. There is a tremendous dearth of capacity in the country, which means, an equal opportunity for all players, from providers to the service providers, to play in the market, which means at the taxations, a look at the been implemented over the last 1 year, which actually makes it more affordable, for the service providers, and then it goes back. I think that's the most one important thing. We speak about standardization. I think not only of clinical outcomes, but HCPs, or the healthcare professionals who serve on a daily basis. So how do we build capacity, and is there a way and possibility of standardizing the education, for all of these guys? That's one of the big learnings. As you want to increase and scale up operations, that will become like a defining moment. My last thing, and a very short, this thing is that the government probably should look at us as partners. I think we heard G20 of medical devices and healthcare fraternity in the morning. Probably you can look at D10, where 10 people can come together, including the government. We would want to partner and look at how we can help you in not only having probably a renal registry. We heard about it. Looking at standardized outcomes, standardized delivery of outcomes to the patients of India. I think if these 3 or 4 things are done, we truly believe that from here to then, this program will be a great success, and we wish everyone the very best. Yeah.
Thank you, sir, for your views. An absolutely crucial aspect.
If you allow me,
Yes, sir.
I forgot to mention, certain developments. The government has now this time included the vascular SS charges. It was missing in that whole program. So this year onwards, the vascular AV fistula making charges 6,000 rupees for the first time for a successful AV. This reimbursement provision has been added, as well as we have included the EPO, the drugs, as a mandatory. So when you are having any in the revised bit, you must consider these with the access, because many places, I'll tell you, I visited Sikkim and Manipur and Nagaland. There nobody wants to go there. Firstly, the volume is less, and secondly, they have very issues of machine maintenance, the technicians, plethora, and there is no surgeon in Sikkim. Can you believe it? So I suggested, ki, why don't you use a DNB training program to get these residents who are doing the private medical college training, and at least. So the vascular access is another gap, very big, which we did not discuss. So I thought, okay, I'll just tell you that this has also been to be looked after, and my request would be that for these inaccessible areas, we must develop an ecosystem and encourage service partners and promote them to go there and set up the dialysis units. Thank you.
Sir, it's extremely encouraging to hear that the government is including the vascular access. But one humble request, which we would put to you to take forward to the government, that vascular access remains a very critical area, the main challenge being to find out a competent vascular access surgeon, a vascular surgeon. Now, we as a company run 3 clinics in Mumbai, and we know how difficult it is to get a skilled surgeon. So government should look at developing that part as well, along with the infrastructure. Charges being included, great news, sir. But we would really look forward to the government to build up the infrastructure so the benefits can actually be translated to the patients. Thank you.
Thank you, Dr. Chaudhary and Indraneel sir, for your views. In fact, Indraneel sir, I'd like to call upon you to please elaborate to us on what are the solutions for the human resource requirement for dialysis presently.
Okay, Shambhavi, we spoke about human resource being one of the major challenges. Before I take on the bigger challenges for dialysis technician and nurses, I would like to, first of all, compliment the government. They are really doing great to ramp up the number of nephrologists in the country. We see everywhere DM and DNB seats are being increased. However, the current run rate may not be sufficient to meet the asking rate to win the match. So one solution for this can be something in a very, very small and minuscule way we as an organization follow. We have tied up with different universities globally. Westmead in Australia, John Hopkins are some of those, where we send MD physicians to get a course, a fellowship program done there. These people come back to India, and we are very proud today that some of them have gone to interior parts of the country like Satna and Jalna and those parts of Maharashtra, and they practice basic nephrology. They are obviously not qualified nephrologists, but basic care they can provide before the patient is being transferred to a tertiary care center. So the government should look at these options. This is something because we have large apex institutes in our country which are globally respected. AIMS, SGPGI, PGI, CMC Vellode, these are all king of institutes. So we should look at some short course fellowship program where interested MD physicians can be enrolled in this program and they can be trained on basic things. Now let me come to the next part, which is the dialysis physicians, the doctors who manage the dialysis centers daily. Now this is a very routine job. So basically we are now very, very hopeful that the government will favorably look at the suggestions in the white paper, wherein we have said that we have recommended that plain MBBS, BHMS, BUMS and Ayush doctors should also be favorably looked at with proper adequate training. This would ensure that there is enough workforce available. The challenges with an MBBS doctor is the turnover is too high. I'm sure we employ about more than 100 MBBS doctors and we see an attrition rate of more than 55-60% because they simply want to pursue something else after a period of time. So this option of looking favorably at BAMS, BHUMS doctors and other Ayush doctors, it will also give them enough professional happiness when they do something like dialysis. Now let me come to the next part, the most important part, dialysis technicians and nurses. So I would say that a lot of work has already started on that along with the government and NATHEALTH. There's a need clearly to set up very clear-cut, concise, and precise programs to scale up the available resources. There's a large number of available resources in the paramedics of the country. Short courses can really help them to manage these dialysis centers. The long courses are already available. Many of the private players do run the long courses, but that will take a little bit of time before the actual workforce comes into the picture. The short courses can be very, very important. But one important thing we as industry need to be very, very cognizant, and the government needs to look at this, is to ensure employment for these people who pass out. Because unless you have that, you will never have adequate people. It's been 8 years that we run a school of dialysis technology, which is accredited by All India Council of Technical Education, and we run it with Tata Institute of Social Sciences. We have trained more than 1,600 technicians so far. But we still see there is a challenge when we enroll the patient, when we enroll the students. The simple factor is many of them feel what will happen to the employment. So this is something we need to look at. The government needs to build on that. Once that is taken care of, then I think the plan that is there, already mentioned in the white paper, that will be very, very successful. The last point I would like to mention about the human resource, giving the training at one time is not sufficient. There has to be a continuous knowledge updation, which is very much important. Unless that happens, we can see a major challenge. And another factor is which we as an organization are looking into this, that because you see, providing proper dialysis is to some extent a monotonous job. So artificial intelligence can be of immense help in this. There are certain factors, there are certain ways in which we are working to ensure just that the SOPs, what has been laid down. Because, you know, for a service provider like us, who operates in 9 states, nearly 200 centers, to ensure that the SOPs are being implemented is important, and that is the case with all the service providers, I'm sure. So artificial intelligence can play a major role to ensure that the implementation is happening properly. Thank you.
Thank you, Indraneel sir, for providing us such interesting insights on every aspect of the human resource requirement in dialysis. Now I'd like to request Dr. Pokhriyal for providing us what are the key clinical outcomes. This is also an important component of dialysis delivery. What are the key clinical outcomes which need to be recorded and monitored to reduce mortality?
Thank you, Shambhavi. At the onset, dialysis is not just a procedure. So let's not think of it as a procedure. The patient comes in, gets 4 hours of dialysis done, goes back home, and that's it, we're done. Dialysis has to be considered, it is a medicine. Dialysis, medicine can be quantified. You can quantify how much dialysis your patient has received. You can quantify how well you're delivering that dose of dialysis. And for that, so, you know, we've all spoken about quality of dialysis, good quality of dialysis. So good quality of dialysis is not just having a RO plant which works, or having, you know, good machines or German machines. When you talk about quality of dialysis, you're looking at quality of dialysis which improves the longevity of the patient, which gives them a better quality of life, which is the purpose of delivering dialysis. Now, to that end, the number one parameter which most dialysis units and as nephrologists we use is something called urea reduction ratio, which can be done very easily. It's a very simple test. Do a blood urea level before dialysis and at the end of dialysis, and see how much urea you've reduced in one dialysis session. Anything above 65% is considered acceptable. And it's a very simple way of doing it. Most dialysis units will do it once a month. This is for dialysis dose. But how are your patients doing? Looking at outcomes on dialysis. So you can look at certain parameters. Hemoglobin levels. Kidney disease causes anemia because the kidney produces a drug, a hormone called erythropoietin, which we supplement to patients on dialysis. If we can get your patients within the targeted range of 9.5 to 11.5 grams of per deciliter of hemoglobin, you're doing a good job. You don't want to go beyond 11.5 because that increases their cardiovascular mortality. So if most of your patients, majority of your patients are in that range, that's one parameter we look at. We also look at serum albumin, which is a very good marker of nutrition of our patient. So if my patient is getting dialyzed adequately, if my patient is getting dialyzed 3 times a week, their appetite is better, so they eat better, they assimilate proteins better, and their serum albumin reflects that. So serum albumin level. So hemoglobin, serum albumin, mortality. Now there is a bit of a skew in measuring mortality on dialysis. Unfortunately, in our country, it's going to be bad in the first. As a mortality or adequacy of dialysis predictor is a good thing. How well you are doing dialysis, how well your dialysis unit is performing is also reflected in your seroconversion rates. Since dialysis is a blood-based therapy, a patient comes on a dialysis machine, gets dialyzed for 4 hours, goes back, and next patient comes on that same machine. There is blood exposure all the time. So dialysis units are hotbeds of hepatitis C and hepatitis B virus transmission. You can measure your viral transmission rates, or what we call seroconversion rates, and see how well your unit is doing, how well universal precautions are being followed. It's also a reflection on how well your technicians are trained, how well your nurses are trained, how well your disinfection processes are. And so this is another parameter that you can look at. The ENY paper talks about per minute into the dialysis machine, which no vein in the body offers. So we need to construct something called an arteriovenous fistula or an Now, this is an accepted parameter worldwide, but again, given our very unique situations where patients kind of resist starting dialysis, resist doing any minor surgeries related to dialysis, it's unfortunate. Very small numbers will start dialysis with a fistula in place. Most of them will require a central line insertion, which predisposes them to line infections, bacteremia, sepsis, and an early mortality. But if I was to, for the sake of simplicity, take 3 or 4 parameters. One would be urea reduction ratio. Second would be hemoglobin. Third would be serum albumin levels. And number 4 would be seroconversion rates in my dialysis unit. Thank you.
Thank you, Dr. Pokhriyal, for your inputs. And I'd like to request Dr. Pense now for talking about community healthcare. What role can community healthcare play in universal dialysis?
Thanks again, Shambhavi. And specifically talking about dialysis, especially peritoneal dialysis, which is a good alternative to hemodialysis. And in the evolved healthcare systems, it's around 12 to 13% of the patients who use peritoneal dialysis as the alternative to hemodialysis. In our country, it's around 6%. So there's obviously a lot of ground to cover. The first thing is about creating awareness amongst the community and also amongst care providers. That what are the benefits of peritoneal dialysis? Why is it a good alternative, and in whom this alternative should be considered? So apart from access to dialysis, I think it's also access to information, because creating information is probably much easier in today's time, thanks to mobile health, thanks to e-health platforms, etc. So that can be done. The first point of contact or first point of assistance for a large majority of the patients suffering from end-stage renal disease happens to be the community health worker, like the ASHA workers, etc., or even the smaller hospitals, health centers, etc., in the public settings. So creating awareness there, creating some kind of a supportive framework for dialysis, and especially for peritoneal dialysis also. Maybe having some kind of registries under PD coordinators at the various various levels could be a good start. Of course, given the fact that, educating people about peritoneal dialysis is not very easy because, the system of being plugged to a dialysis machine 3 or 2 times a week has become so deeply entrenched and well understood by everybody that, educating that, there is an alternative within the body to a dialysis membrane is a little difficult for people to understand. But there are great benefits to peritoneal dialysis, particularly in certain segments of the patient populations, and we need to, utilize them. Uh, a well-formulated, strategy with nephrologists as well as dialysis nurses, dialysis technicians that we have been talking about, supporting PD will go a long way in helping bridge this gap and providing, PD as a good alternative to hemodialysis. The other part related to that is making access available in terms of consumables, etc. Let's say, CAPD bags, I think we were talking about, and certain things which the government can do to facilitate the availability of CAPD bags and consumables at various levels would also be very, very helpful in driving forward, taking forward the peritoneal dialysis initiative as part of the overall One Nation, One Dialysis, spectrum. Thanks.
Thank you, Dr. Pense, for highlighting the role of community healthcare. Now, finally, the medtech industry. What will be the role of the medtech industry in the One Nation, One Dialysis program, and what support may the government provide to enable this industry? For this, I'd like to request Mr.
So the success of One Nation, One Dialysis, I think among many pillars, three important pillars, all of us have talked about are accessibility, affordability, and skilled manpower. I think MedTech plays an important role in all these three pillars. Accessibility or capacity building will be difficult to do unless and until MedTech is and working on an endeavor to bring down the equipment cost. And that's what I think what we have been trying to do. So more we bring down the cost of the equipment, the accessibility scale up or capacity building scale up would be more sustainable. And on the affordability side, what the price to a payer, the consumables have an important big chunk as a part of that. So if as a medtech, not if, we are working on bringing down the cost of the consumables, and probably the day we are able to do that, the affordability will better up. So accessibility and affordability, skill upgradation of the fraternity would be more effective, and dissemination would be better if medtech is made a partner to that. So that's what I said. Optimum quality dialysis procedure would be accessible and affordable throughout India, only when the medtech is also accessible and affordable. So if you can't make medtech accessible and affordable, I don't think the procedure will become accessible and affordable. Then it's a 50-50 love, right? So it needs to be worked on both sides. So now coming to the ask if I have from the government, so allow me to take a liberty to present that. We all talk about localization. I think to go self-reliant, localization is the only common essential solution. There is no other solution when you have to go self-reliant. Now, localization, here are my 3 or 4 pointed asks. Right. The first ask would be a quality control audit or an order for all localized and imported consumables, right? Especially when it is imported to some nearby countries, right? So there is presently no quality control orders being followed on that by the government. Second, misuse of FTA to dump in unconfirmed quality product. Right? It's a loss of quality for the patient, and it's a loss of revenue for the government. So that's something I would request the government to look at it. Last but not the least, while production-linked incentives and probably trade barriers or tariff barriers, my apologies, are good to have, but they will not help to go for localization to go taller unless and until the government also tries to motivate the localized to participate in their demand, the demand they are creating. The government creates a lot of demand when it comes to as a consumer for medtech. As if you want the localized to go taller, you will have to start motivating them by helping them participate in their demand. You still have local participations wherein USFDAs and CEs, etc., are mandated. I don't think that's given. Right? You don't need these for Indian procurements. So that's what these would be my key asks. But yes, uh, at this platform, I think I can very well be happy to say that dialysis is one a rare therapy wherein the hardware and the technology is mostly now capabilities are around to localize. Right? As we talk, we are in process of testing our prototype of first truly made in India dialysis machine with almost 70% local content. And hopefully within the next 3 months' time, we'll be able to commercialize that. So yes, scales will not be around, at least for the next 3-4 years or 5 years. But yes, the things have started. Thank you very much.
Thank you, Mr. Sardana, for highlighting how various aspects of trade, PLI, and so many other things also play a role in this medtech industry and what all we still need to do to actually bring it up to par to support the service providers to actually ensure quality dialysis. Thank you so much, sir.
So if you permit, I just wanted to add the great news hearing that, 70% indigenized component, and we are looking forward to have some manufacturing facility in the country. And this is a great step. I think it will bring down the affordability, that issue. I would like to request everybody, whoever is present here, that the IC creating awareness is very important. May I request on behalf of the government that you all are doing such a wonderful job. Why don't you all have success stories from your centers and push it in the YouTube and all so that people read those? There is some sort of anxiety or apprehension, dialysis guy, it is a catastrophic event. Very true. But let the people also know that there's a solution till you get a renal transplant. And I think if we can push success stories in the media, it will reach a large target audience. And the dialysis promotion will be that very easy, little bit of easy, so that people come to our dialysis centers and they early report. That's all.
Thank you, Dr. Chaudhary, for your views. I'd now like to request Mr. Rajneesh Gupta, the Associate Partner, Ernst & Young, in the Tax and Economic Policy Group, to please come up on stage and provide us the key insights from this panel discussion and also the macroeconomic picture of India and how we are going forward.
It's been a great panel discussion, and the passion of all the people and the expertise that they have. And what is very outstanding about the panel was it was both rich in details as well as on the big picture which was there. So there was nothing missing over there. We at ENY had recently done a report looking at what India may look like in 2047. And we had actually projected the Indian economy can go up from $3.5 trillion today to about $26 trillion. But one of the assumptions which was over there was that we have a huge demographic dividend and India needs to provide great healthcare and education to our young workforce if we have to really grow. And so this thing is very important, what we have talked about. So the panel really started with talking about the challenges which are there. And I think it was quite clear that there's a big demand-supply imbalance which is there, reflected in the amount of debts which are there, reflected in the coverage which is there. And the fact is that last mile connectivity is a challenge. Anybody can have this problem anywhere in India, while the medical facilities tend to be clustered around the larger cities. There was a discussion around, there were two conflicting policy objectives which are there. On one side, it needs to be affordable and accessible, yet the system needs to be designed in a way that it's commercially viable. And then there were issues around payments to be on time, the reimbursements to be right. We also talked about education of both the care providers as well as of the patients. So that the patients come very early, which is there. A discussion around the need for standard, predefined quality standards, as one of the panelists said. And then these centers require manpower, which again is in a shortage. The supply chain is required for all the consumables to come. And then the delay in the empanelment, and that the outcomes should be measured, and the volumes are required for the cost really to come down and for the whole thing to be scaled up. These were some of the issues which were identified. And then more importantly, there were suggestions which the panel made. And it was really around for the private sector to partner with the government. And the first set of recommendations was around designing the PPPs, right, so that you actually have participation. And as one of the panelists pointed out, that they are going overseas, setting up centers in other countries. So entrepreneurship, capital and all is not a shortage. It's a question of getting your PPPs right for really some of these investments to flow in and for the infrastructure to get created. Timelines should be right along with the life of the equipment, 10 years, and then the way they are designed in terms of the hubs having the right amount of beds which are there, and some of the requirements which are there of having 2 to 3 bed centers in small places may not work, because it's a volume driven business. So you need to get those things right. And in terms of what may be the manpower requirements which are specified in PPPs, so they need to be little realistic based upon what is possible. And then of course about the timely reimbursements and publishing the outcomes. There were also suggestions made about the taxes and duties to be looked at, so that they are right and can make the whole ecosystem more affordable, which is there. Standardization of education and having the training standards. There were a few recommendations which were made around the training of the human resources, because without having the right people in small parts or smaller cities or in clusters, this thing is not going to work. And one of the themes which was coming out was to provide adequate training, to have short courses to get the workforce be available on time, and for the requirement of a continuous knowledge upgradation. And as the panelists said, that we have a lot of world-class institutions which are over here in India. So it's actually working on the details and getting some of these things right, which is there. Outcomes was really talked about, and we had a lot of suggestions on some parameters like the hemoglobin and other things which can be measured, so that you know that the treatment is on the right path. And as the panelists said, that dialysis is a medicine and longevity of the patient should increase. Then there was a talk about awareness, of building up awareness, both in the context of PDS and otherwise. And it was really the education needs to be given both to the caregivers as well as to the patients. Both of them need to be educated. And from the government side, there was a suggestion that YouTube videos be made, and there is more publicity which is given to the entire thing. And finally, from a medtech perspective, the recommendation was on localization, to have greater localization. And as you know, the volumes were to go up, I'm sure that this would be possible. So with that, I end my summary, and thank you very much.
Thank you very much. A sincere thanks to Dr. Ranjan. As NATHEALTH, under the guidance of NHSRC, we will continue this objective of bringing stakeholders together and continue this agenda going forward for improved dialysis delivery. Thank you to the panel as well as an ENY for the paper. Thank you very much.
Thank you to all our panelists for reflecting on the operational infrastructure and the capacity challenges and the recommendations. We'll close with a group photograph. Thank you to Rajneeshji also. May I request you to please join for connecting the dots and presenting the summary of our recommendations, discussions of this session. And ladies and gentlemen, we are going to be planting 50 trees on behalf of all our panelists of this session. this session. That's going to be there in Deoghar, Jharkhand, AIMS. Thank you to them for being partnering with us in this green drive. Thank you. So with that, ladies and gentlemen, we now invite you for lunch. But before that, once again, I would like to invite our RJ Ria, who's going to be taking over from here. Some quiz, some goodies, and then lunch, ladies and gentlemen, we have also outside. It is also in the basement. Big thank you to our sponsors also of this session, DSPI, and to our knowledge partner, CNY. Over to you, Ria.
Thank you. So I know everybody is very hungry, but I request all of you to be seated for like next 10 more minutes because we'll quickly do the second round for the quiz, and then we all can proceed for the lunch. Before we start with all these technical questions, again I have come with one of my very basic questions, which obviously you guys would know because you are from the media. Medical fraternity. I'm from the media fraternity. So. Who can answer this question? How many times a day you must take medication if your prescription reads QID? Who can answer me that? Yes. Quickly, I saw sir raising the hand. Say your name.
Raj Kapoor.
Oh, we have Mr. Raj Kapoor with us.
4 times a day.
4 times a day, which is absolutely the right answer. Thank you so much. But for this, you're not getting any goodies. But yeah, the question that you can see on the screen, please scan the QR code if you haven't already. And if you have, you will have this question. You can answer on your mobile phones. The question says, what is the target of Health Ministry and the 15th Finance Commission to boost the public spend in healthcare by 2025? Who knows the answer? I'll come to the ma'am. You were the first one to raise hand. Ma'am, your name, please.
Pooja,
So we have Dr. Pooja with us. So
5%. 2.5% of GDP.
it's 2.5%. But she raised the hand, so I'm so sorry. Right. So can we have the goodies? 2 goodies, please. One for sir also. Sir, Mr. Bose, we interacted also right now, so it's great. And you actually gave the answer.
Question, but anyway, ladies first, you know. No booklet, huh? Thank you, Siddhartha. And Ria, you're Ria, yeah.
Yes, please, ma'am. Thank you so much. Ma'am, how are you liking the summit?
Yeah.
Perfect. So, can we move on to our next question? Guys, see, a lot of people are winning the awards. I think people have either they know the questions already and that's why they're answering it so correctly, or you guys have like brilliant heads, not like me. I had to literally Google the answers for these questions. What is the next question? Okay. When was Pradhan Mantri National Dialysis Program launched? And can anyone tell how many dialysis centers are there under PMNDP? Nobody knows this answer. Only one hand. Ma'am, please come. Please come forward. Please come forward. Please come forward. Just one. Okay, sir already knows. Oh, you have launched the program, so we can know more about. Okay. So you can ask somebody else if they don't have answers. So please come here. Quickly, we'll finish with this and then we all can have lunch. मुझे खुद बहुत भूख लगी हुई है. So I will not ask you all to wait for too long. Sir, yeah. Say your name.
I'm Rahul.
You're Rahul. नाम तो सुना होगा. Are you a SRK fan? Like a very random.
Yes, I am.
बताइए किस मूवी में उनका नाम राहुल है?
Most of them.
Most of them. One of the movie that you know?
कल हो ना हो.
कल हो ना हो. Okay, कल हो ना हो में राहुल नाम नहीं है. But okay. That is the right.
Thank you.
Kuch kuch hota hai is the right answer. Obviously, you are from the medical fraternity and you would know things about related to medical more. मैं media से हूँ तो मुझे ये पता था पहले. Plus, those who don't know, not to flaunt, but my date of birth is 2nd of November, which is also Mr. Shah Rukh Khan's birth date. So I'm a big fan of his also. So sir, give me the right answer.
So this program was launched in 2016.
2016. And how many centers are there?
It's more than 1350. I think it's the old data, if I'm not wrong. This is more than 1350. Initially, they launched with 1350.
1350 centers initially. So he's claiming that the data that is showing here is wrong. The numbers might have increased. But let's see what's the correct answer. 1350 is the right answer. Can we have the goodie bag? Thank you, Mr. Rahul. Thank you so much. We move to the next question. One last question, one more winner. And then we all can go and grab the food. Question. What is the estimated total number of people living with CKD in India? First thing, what is CKD? Who can answer me that? What is CKD? Chronic kidney disease. See, I'm the only one in this room who does not know any of these. But okay. Who can give me the right answer? Some hands, some hands. I saw that guy. Mr. You know the answer? Okay, you were calling somebody else. Who knows the answer? Who knows the correct answer? No one? Somebody want to make a guess? Okay, Mr. Raj Kapoor. Please, come, sir.
65.
Sir is saying it's around 65 lakhs. Let's see what is the correct answer. Can we have the answer? Oh, 40%, 40%. Oh, the correct answer is 78 lakhs. Nobody takes the goodie bag. I'll take the goodie bag. Okay, thank you so very much for this quiz round. We'll be playing more of quiz rounds. There are a lot of goodie bags. And please go have your lunch, come back, and enjoy the sessions. This is your host, Ria. Thank you.
Thank you so very much, Ria. And a big thank you to also our sponsors for the gifts, to Krishna, to O3 Capital, to Map My Genome, and also to Nephro Plus. With that, we break for lunch. Ladies and gentlemen, lunch being served outside and also in the basement near the Regency Hall 4 and 5. 2 o'clock, we are going to be starting with the next session. That's on health financing. Then we are going to be having 2 panel discussions also. The session lead, Mr. Sunil Thakur, the Treasurer, NATHEALTH. Thank you also to our sponsors. As we thank our sponsors, here are the sponsor videos which you can see on your screen right now. Big thank you to them.
Hello.